Good evening. Thank you all for coming out this evening. We're going to be talking about freedom from fractures, which means how to avoid broken bones. And this is sort of being done in partnership with American Bone Health, which is an organization that helps osteoporosis education and research. We're going to have a number of presenters this evening. I'm going to start off, and then Dr. Russell, Dr. Guest, and Aaron McConnell will be talking and giving different parts of the program. So what we're going to talk about is, well, what is osteoporosis and what are fragility fractures? We're going to talk about what actually goes on in bones, how they work, what they do all the time, and some reasons why bones might break. We're going to look at the risks for broken bones, fractures, and how to assess that risk. And then we're going to look at some ways that we are working here at Christiana Care to reduce the number of fractures, and ways that you can reduce your risk of fracture individually, both through medication, through modification of risk factors that you can modify, fall prevention, exercise, and so forth. So I hope that this is useful for you. What we're going to start off with is something very basic, and this is sort of the most sort of boring slide in the deck here, and this is about what is osteoporosis. And osteoporosis is defined as a metabolic bone disease characterized by low bone mass and microarchitectural deterioration of bone, which leads to enhanced bone fragility and increased fracture risk. There's primary osteoporosis, which is osteoporosis that happens just because of aging and no other real cause. And there's also secondary osteoporosis, which is related to some other particular cause. The other important thing that is really sort of a touchstone of this presentation is the concept of fragility fracture. And that refers to a broken bone resulting from relatively low trauma, such as a fall from standing height or less. Bones really are strong enough, or should be strong enough, that they shouldn't break without major trauma. So a fall from standing height really should not break a bone, no matter how hard the surface is that you fall on. So a bone that breaks from low trauma is considered a fragility fracture, and we'll talk about why that gets important. So when you think about the structure of bone, bone actually is a fairly complex organ. There's the outer shell of the bone, which is called the cortical bone, and then on the inside, as you can see from this bone that's been sliced, there are these thin little spicules of bone, and as you can see from this section of a femur here, they're arranged so that they reflect the stresses on the bone. The inner cortical part of the bone, or I'm sorry, the trabecular part of the bone, which is the inner meshwork, is really what gives the bone most of its strength. Because if you didn't have that inner part, it would be like an eggshell. It would be very fragile because it would be hollow. So the trabeculae inside the bone are really what give it the strength. So one important thing to know is that bone is not just a piece like a piece of wood or a piece of steel that holds your body up. Bone is an active living organ, and it's constantly doing things. And what happens in the bone is that there is a so-called remodeling cycle where you start with healthy bone, and then little fractures can occur. The bone can develop a weak spot. And then you have cells that come in and chew up that part. The weakened bone gets cut away. And then there are osteoblast cells that serve to remineralize the bone and repair it. A good analogy for us is road work. We're now in pothole season, right? So what happens is that you have a road surface and it gets cracks in it, and then the water can seep in and you can develop potholes and so forth. So what happens next? Well, you get guys that come out and dig it all up. And these are the analogy of osteoclasts. They are cells that come in and chew away parts of the bone that are damaged. And when you're done, you have a big pit like this, okay? Now you can imagine that if the osteoclasts were to run out of control and not stop when they're supposed to, you would get a problem. You would get big holes in the bone that would be problematic. But luckily that doesn't happen because you have other cells called osteoblasts who come and fill in the holes and patch the fractures and the broken parts, and you wind up with a nice smooth patch and brand new strong bone. So the bone is constantly doing this. It's all being dissolved in one place and being laid down in another place. And actually, this is a pretty complicated process. There are lots of regulatory pathways that control these blue osteoblasts and the purple osteoclasts, a lot of different factors, so that by and large, it keeps things in balance, and the bone remains healthy by doing that. So over the course of a lifetime, what happens is, this represents a lifetime, and this is shows bone mass over the course of a lifetime, and you can see that from birth, both men and women. Women are shown here in red, men are shown in blue, and up until about age 25, you're still building bone. Then between about 25 and about 40 or so, things sort of stabilize, they plateau, and then what happens is that both men and women start to lose bone mass. What you can see from this graph, though, is that men build more bone than women, and then when they start to lose bone, women lose bone faster than men. It's not fair, but unfortunately it's the way it is. But that's sort of what we have to deal with, and it's related to the balance of those osteoblasts and osteoclasts that are building bone and chewing up bone. So what happens in osteoporosis? Well, osteoporosis is where the destruction of bone outpaces the rebuilding of bone, and so the trabeculae get weakened. As you can see, they get all thin and not as dense and not as complicated a meshwork, and so they're not going to be as strong. And what happens if a bone is not strong? You get fractures. And these are fragility fractures, and this is a display that was put together by the National Bone Health Alliance, which has casts that represent the number of fragility fractures that occur in this country in one day, which is about 5,500 fractures a day. All told, in the country, that's about 2 million fractures each year. We just did some review of our data here, and we see about 3,000 of these every year here in the Christiana system. And this is a major problem because it means that about half of women and up to a quarter of men will break a bone due to osteoporosis. And it costs billions of dollars to treat all these patients. Many patients, especially if they have hip fractures, really never really regain full mobility. And for many people, that's a sort of really a life-changing event. The good news is that if you know what to do, almost half of these fractures can be prevented by taking the proper measures. Now, osteoporosis is associated with a number of different things. There are a number of diseases that are, some of which are exotic and some of which are very common. Diabetes, chronic kidney and liver disease, rheumatoid arthritis, and a few others that are associated with increased bone fragility. And there are also a number of medications that are associated to varying degrees with loss of bone strength. Steroids or glucocorticoids like prednisone and so forth are very well recognized. Anti-seizure medications have been recognized for quite some time. Of great importance in the current day and age is aromatase inhibitors, which are very, very commonly used to treat breast cancer. And there's a number of others, proton pump inhibitors that many people are on. But these are all, at some level may be related to osteoporosis. Now, osteoporosis is also related to a number of other conditions. One of them is smoking and excessive alcohol use, more than about 3 drinks a day, deficiency of either calcium or vitamin D, gastric bypass procedures where your intestines don't absorb the nutrients in a normal way, celiac disease, and so forth. So there are a number of conditions like this that can contribute to osteoporosis. So what can you do with all these things and all these factors? Well, one of the most important things you can do is know your own risk and find out about it. And what can you do for that? You can get a DEXA scan. DEXA stands for dual energy X-ray absorptiometry. What it does is that it's a painless, very simple, very quick test which scans the hip and the spine and measures how much bone calcium there is in that area. And there's a lot of data about this. We in other words, there are normal databases, and we can know from that how much bone there is, and that gives us some measure of how strong it is. What a DEXA scan tells you is what the bone mineral density is, but the important numbers really are the so-called T-scores and Z-scores. And the T-score is how much the patient's bone density differs from that of a young normal adult. There is also a Z-score, and the Z-score tells how much the patient's bone density differs from peers of his or her own age and ethnicity. You would think at first blush that the important thing would be the Z-score because it compares like with like, but it's actually not, because everybody loses bone, and so you want to compare a patient with a normal situation, which is what you are when you're a young adult. So that's why the World Health Organization has defined osteoporosis based on the T-score. And the T-score is in standard deviations of difference. A T-score of -1 or greater is normal. A T-score between -1 and -2.5 is considered to be low bone density. It used to be called osteopenia, but people don't really use that term very much anymore. It's not really a diagnosis. And then osteoporosis is defined as a T-score of -2.5 or less, or a fragility fracture of the hip or spine. That makes a clinical diagnosis of osteoporosis. But because of this, the DEXA scan is really the number one way that you diagnose osteoporosis in the absence of having a broken bone. So it gives you a way to start figuring out what your risk is. Now that makes sense because your fracture risk roughly doubles for every standard deviation that your T-score goes down. Okay, so the lower your T-score gets, the higher your fracture risk gets. okay? And that's how the diagnosis is made. But there's more to fracture risk assessment than just the diagnosis of osteoporosis or not. And here's an example of that. What the red bars on this graph show you is the fracture rate. And as you can see, the fracture rate goes up as the T-score goes down. Okay, you've already seen that, you know that. But the gray bars are also important because they are the number of fractures that actually occur. And if you notice, the most of the gray bars are highest when the T-score is in the -1 to -2.5 range. In other words, there are more fractures in people with just low bone density than there are in people with osteoporosis. And that's because there are so many more people with low bone density than there are with osteoporosis. So what you need to do is, if you have low bone density, what you try and do is figure out whether you're at higher risk or lower risk. And there are ways to do that. The absolute fracture risk is also very important because that's how doctors and insurance companies decide whether treatment is indicated. You're eligible for treatment and your insurance company will pay for it if your risk of a major osteoporotic fracture is 20% or greater in the next 10 years, or if your risk of a hip fracture is 3% or more in the next 10 years. So this is another reason why absolute fracture risk is very important and why we include this in DEXA scans that we do. So your overall fracture risk depends on your age, gender, your height and weight. Any prior fractures means you're at greater risk. Do you smoke? Did you have a parent break a hip? Have you ever had steroids? Do you have a chronic condition? And a number of other factors. So the trick is to take all of this into account. And for this, we use fracture risk calculators. Here's an example of one, the World Health Organization FRAX tool. And what it is it's an online tool that you put in your answers, your age, your date of birth, and click your risk factors. You then click calculate, and it gives you a 10-year fracture risk. Okay, you can do this either with a bone density, a DEXA result, or not. You can just put in the risk factors. There is another fracture risk calculator, the American Bone Health 4 fracture risk calculator. Very, very similar. Same sort of idea, but these are both tools that people can use to determine what their fracture risk is. And you can also sort of play with it and see if you were to change your risk factors, how much of a difference it would make. Another thing that we do here at Christiana Care is that we do another measurement when we do DEXA scans. We measure what's called trabecular bone score. And what that does is that it measures the microscopic heterogeneity or homogeneity of the bones, which gives us an idea of the quality of the trabecular architecture in the bone. And we use that to modify the fracture risk measurements to make it more accurate. So what can you do? You can modify the risks that you can modify. Now, some of them you can't modify. You can't change your gender or your age or your ethnicity or family history and your diseases. But there are some things that you can modify. Smoking, sometimes you can change medications. You can moderate alcohol use. And you can also do dietary measures, which we'll talk about, and also fall prevention and exercise, which we'll talk about later. So calcium is very important because calcium is used to build bone. The average American diet provides less than 600 milligrams. All postmenopausal women should receive probably about twice that. And we lose a good bit of calcium, but it's important to get enough calcium. The best way to do that is by eating a normal healthy diet with that contains the calcium. Sometimes supplementation is indicated, but a good well-rounded diet gets you well on the way. And there's also vitamin D. Vitamin D is really important in bone metabolism. It also helps your GI system absorb the calcium that it needs to build bone. And the issue with vitamin D is that it is actually in very few foods. Fatty fish is the one, but you can only eat so much mackerel, and so it's hard to get. Vitamin D is largely comes from your skin, produces it by exposure to sunlight. We don't spend much time in the sun anymore. We're all working on our computers, and we're not supposed to be out in the sun without sunscreen anyway. So many people need supplementation of vitamin D. Sometimes what is done is that you may need to test your blood levels and see if you're low, and if you're low, then you can get supplementation to help you get up to the right level. So here at Christiana Care, we've been working for a number of years to sort of try and reduce the many fragility fractures that we see. And one of the things that we've done is that we now have nurse navigators. Angel and Erin in the back there, are nurse navigators, and their job is to, when patients are identified who may be at risk, they help to see that they know what they need to know and get to where they need to get to so that something can be done. We also have a group of providers from sports medicine and rheumatology and endocrinology and women's health who will work with primary care doctors who may not have the time or the interest in doing bone health stuff. And the Strong Bones providers are there as a resource, so that all the primary care doctor has to do is say, go see the Strong Bones program, and they'll take care of the bone issues, and then they can get a recommendation and go from there. We've also started a fracture liaison service, which means that one of the things that happens when you have a broken bone and you come into the emergency room and get the broken bone is that if you can be identified, then we can contact either the doctor or the patient and say, look, this patient had a fragility fracture. That's something that you should be worried about because they may be at risk of more of them, and so that the bone health and the bone fragility gets taken care of along with the fracture. And we've also developed some clinical care pathways. We've developed an osteoporosis pathway that sort of helps providers in the community and in our system have a sort of a unified approach to the best practices to treat osteoporosis and be able to more easily access the resources that they need. So what you can do is know the importance of fragility fractures and know your own risk factors and know your own T-score and your own fracture risk. Get a DEXA scan if you don't have one. Know your T-score because that will really help you know what you need to do. You can modify those risks that you can, take into account nutrition, calcium, vitamin D, things like smoking, and importantly, learn all you can and talk to your providers about bone fragility, because increasingly there are things that you can do, and you can reduce your risk of fracture by about half by getting the proper treatment and modifying the risk factors that you can. So it's actually very powerful what you're able to do. So with that, I'm going to pass the baton to Dr. Russell, who's going to talk about some medications.
Okay. Thanks, Dr. Menzo. I'm Dr. Russell, Eric Russell. I'm a rheumatologist here at Christiana. Thank you for listening to me talk a little bit about medication and supplements in treating osteoporosis. The first couple slides might be rehashing what Dr. Manzone I kind of already talked about, but just to know that it's extremely common, tremendous medical impact. 10 million Americans have osteoporosis. 1.5 million suffer a fragility fracture with osteoporosis. And one statistic I frequently tell my patients is that 40% of those patients with osteoporosis or low bone density who sustain a fragility fracture, only 40% of those patients actually regain that pre-fracture functionality, that pre-fracture independence. So that's a pretty significant number. I bring this up because it just illustrates how important it is to recognize and then to intervene to prevent that fracture that can really set somebody back. A little bit more about the medical impact. Lots of hospital admissions, lots of nursing home admissions. Very expensive. Here at Christiana, we handle a tremendous amount of fragility fractures. It's important to note that it's a silent disease. This is something that you don't feel. Somebody will come in and I'll tell them that they have osteoporosis. We see it in your hips, we see it in your spine, and they'll be like, oh yeah, my hips have been bothering me. And I tell them, no, that's not because of osteoporosis, it's from something else, osteoarthritis or some other condition. But osteoporosis is silent. You don't feel it until, of course, you sustain a fragility fracture. Then, of course, you're going to feel that. That's why it's so important to screen. Dr. Manzone already discussed what a fragility fracture is. This is what we're trying to prevent with treatment. And again, it's defined as a fracture that occurs from standing height or less. So just walking along, having a fall onto your side, sustaining a hip fracture, or slipping on ice, falling on your backside, and that jarring, falling down, you have a fracture in your spine. Somebody with normal bone, they should not fracture. But somebody with low bone density or with osteoporosis, they can be at risk for that type of fracture. This is what it looks like. On the bottom, I don't know how well that shows up here, but in the spine, what happens is you don't just get a crack in the spine, in the vertebrae. It's a compression. The vertebrae just kind of smushes. And it'll actually wedge, just based on the mechanics of the spine. You'll get this wedge deformity from a compression fracture. And that can be very painful in the acute setting. And that can happen at multiple sites going up the spine. So this is somebody with one compression fracture there, but that can happen at multiple levels. And when that occurs, you can start seeing curvature of the spine, the so-called dowager hump. And sometimes you'll see older individuals that are walking around with big humps on their back, and that's because they've had multiple compression fractures where they've had this wedge deformity in their spine running up their multiple levels. In the hip, a fracture is going to be a crack, most often at the femoral neck. The other common site I did mention is the forearm. So somebody falling forward onto outstretched arms, and they end up sustaining a forearm fracture. These are the most common sites for fragility fractures. By far, the highest risk are women, specifically Caucasian women are at the highest risk. But it's important to remember that men are also, certain populations of men are at risk for osteoporosis and low bone density, patients with risk factors that Dr. Manzone already identified, and men are older than 70. It really should be a thought to consider bone density in somebody, in a male who's older than 70. But again, the Caucasian female women first, but Caucasian women especially at the highest risk for osteoporosis, for fragility fractures from osteoporosis. It's important to, again, for treatment in somebody who's had a fracture, because somebody who's had a fragility fracture, they're at risk for a subsequent fracture. Just like I told you with that person who sustained one compression fracture at a vertebral level, that can happen over time at multiple other levels. So that's why it's so important to consider treatment to prevent a subsequent fracture, because those are the patients that are at the highest risk. So kind of rehashing who needs to be treated. Any postmenopausal woman or man who's older than 50 who've sustained a fragility fracture, that's an automatic diagnosis for osteoporosis, a fragility fracture. Bone density T-score equal or less than negative 2.5, that places them in the range of osteoporosis. Treatment should be indicated. And then, as Dr. Manzone mentioned, some patients who have osteopenia need treated, others don't. And it all depends on risk factors. And that's where the primary doctor, the bone health, whoever's managing the bone health, will calculate whether there's enough risk factors to warrant starting treatment in that specific population of patients who have osteopenia or low bone density, but they're not quite in the osteoporotic range. So to go into calcium and vitamin D a little bit more. As mentioned before, both are very important for bone integrity. They're the building blocks of healthy bone. Specifically for vitamin D, which we'll talk about first, roughly you need 800 to 1,000 units of vitamin D based on the National Osteoporosis Foundation recommendations. Your primary doctor should be checking these routinely, or whoever's managing the bone health. Roughly, once a year, every 6 months. There's no specific guidelines, but it's very important to optimize vitamin D levels because low levels can be a risk factor for accelerated bone loss. As Dr. Manzone mentioned, vitamin D is not readily available just in food. It's predominantly converted to the active form in the skin. It's called cholecalciferol, and that's why sun exposure is important and why it's very common, especially in the wintertime when you're more indoors, more covered up. Patients will often ask me what's better, vitamin D2 or D3, and vitamin D3 is the kind of the natural form of vitamin D. That's cholecalciferol. Vitamin D2 is ergocalciferol. That's available in a lot of prescriptions. Some of you might have been on high-dose ergocalciferol like once a week, for several months to restore levels. Both are adequate at improving vitamin D levels. There's not great studies showing one is better than the other, but if patients really press me which one is better, I'll say the natural form vitamin D3, stick with that. But again, both are effective at improving vitamin D levels. Calcium is the other supplement that's really important, and your body needs 1,200 milligrams of calcium for good bone health, and any more than that really isn't needed. I've had patients come into my office on 5,000 milligrams of calcium in some cases, and thinking that it's helpful for their bones. And I tell them you don't need that much, and in fact, it very well could have a detrimental effect over time by having too much calcium. There's actually good evidence now that too much calcium can have detrimental effects or be a risk factor for cardiovascular disease. And so for that reason, it's recommended that the best and safest way to get it is through diet. Some people need supplements. Some people can't get calcium in their diet. They're vegans or they're lactose intolerant or they have absorption issues and they need supplements. But the best way to get calcium is through the diet. And it's relatively easy. I follow the American Bone Health recommendations, the calcium rule of 300. So what I tell patients is that 3 to 4 servings of dairy or dark green leafy vegetables or calcium fortified juices. If you do 3 to 4 servings of these a day, you're getting that, you're meeting that 1,200 milligram threshold. And so it's pretty easy. Yogurt for breakfast, a glass of milk, a cup of milk somewhere along the way, a spinach salad for lunch, and a scoop of ice cream for dinner. And that's 3 to 4 servings of calcium that you've gotten just through diet. You're hitting that threshold of 1,200 milligrams of calcium a day. I tell patients frequently, you can, if you're doing that and you have a relatively balanced diet, you can stop the supplement. Okay. But again, vitamin D is a different scenario. You do need that supplement. You can't get that just through food. So now we'll move on to the medications, the prescriptions. And before talking about that, I want to talk about bone remodeling, which Dr. Manzone talked a little bit about. It's important to understanding how the medications that we prescribe work. why we're using them. So as he mentioned, the bones throughout our entire life are undergoing a process of bone remodeling where they're constantly being broken down, constantly being built back up. That creates nice, strong, tensile bone that can withstand a lot of force. So what these medications are doing is they're altering that balance. The majority of medications work on preventing bone from being broken down. They work on osteoclast. They prevent the action of osteoclast, which break down bone. So that's by far how the majority of medications work. There are a few that we'll talk about that work on the other end of the spectrum to build bone up, to stimulate bone production. So first-line treatments are bisphosphonates and denosumab. Again, these are medications that work by preventing bone from being broken down. The ones that I recommend, the bisphosphonates, are alendronate, also called Fosamax. It's a daily or weekly formulation, an oral formulation. Risedronate or Actonel is a weekly or monthly oral formulation. Then zoledronic acid is a yearly IV medication. These are all bisphosphonates. These first three are called bisphosphonates. The third, denosumab, is not a bisphosphonate. It still works by preventing bone from being broken down, but it's a different class of medication on how it prevents that. So, but all of these medications are indicated as first-line treatment because they do two things that we look for in a good osteoporosis medication. They increase bone density at the hip and spine. They've been shown to do that in multiple very large trials. And most importantly, they reduce fracture risk at these sites, at both the hip and spine. And we'll see in a second that not all treatments do that equally. And again, they work by preventing bones from being broken down. So which one do we choose? And it often comes down to tolerability, insurance, unfortunately, cost. Alendronate and risedronate have been around for a long time. They're generic, they're cheap, but they're effective. And these are by far the most commonly prescribed first-line treatments for osteoporosis, and they're the ones that I'll use in patients who have, relatively run-of-the-mill osteoporosis. Some patients who present with very severe bone density loss initially. Sometimes, will be more aggressive up front, but alendronate or risedronate are usual first-line treatments. Ibandronate, which is the fourth bisphosphonate available, I have not mentioned yet. This is also called Boniva. This is an oral or an IV formulation that can either be monthly or every 3 months that it's received. This is a medication I don't recommend first line because it does not have the same evidence behind it in terms of fracture reduction, specifically in the spine. So, but with that said, for those patients who are on the medication or been on in the past, does not mean that they have not had benefit from it. But just in terms of specifically looking at the evidence behind these medications, usually this is not the first-line treatment that I'll use. Some of these oral preparations can cause stomach upset. Risedronate, alendronate, and the oral form of ibandronate can cause GI upset. It's relatively common. Anything from just mild stomach, burning, gnawing sensation, to significant heartburn, and in several cases we'll have to stop the medication and move on to something else. And one treatment or two treatments that we'll use are zoledronic acid. That's the IV form of the bisphosphonate. Kind of gets around that GI issue in most cases. Denosumab, Prolia, is given subcutaneously and also usually does not have that same stomach upset issue. So the usual progression for me is start alendronate or risedronate initially. And if it's tolerated, then great, we'll continue it. If it's not tolerated, then I'll usually move on to either zoledronic acid or denosumab. A few notes about denosumab. Again, this is a subcutaneous formulation, so it's given under the skin, and it has to be given by a healthcare provider. So that means a visit to the doctor's office to get it. But it's every 6 months, and it's pretty infrequent, but it's a very effective medication, improving bone density and, again, reducing fracture risk. The other caveat with Prolia And this is kind of an evolving conversation that if somebody is committed to Prolia, that they might need to be on it for the long term, indefinitely. There's good evidence now that patients who are stopped on this medication, they can quickly lose the gains that they've made with Prolia in terms of reducing fracture risk and improving bone density. And that's been shown even within a year of stopping the medication. So with Prolia, at least what I'm telling patients right now, and again, it's an evolving conversation, as a lot of topics around treatment are with osteoporosis. But as of right now, I'm telling patients that if we consider this medication, we're probably going to maintain it for a while. That's not the case with the other medications, and we'll talk about that in a second. A few second-line options that we'll talk about first. These are reserved for patients who don't tolerate the bisphosphonates, who don't tolerate denosumab, who have tried them and they just still have persistent disease. It's also reserved for patients who present initially with very severe osteoporosis, patients with T-scores, negative 4.5, or have had multiple fractures. Sometimes we'll consider these type of treatments initially and then transition to one of the other treatments for a more long-term approach. These two medications, teriparatide and abaloparatide, Forteo and Tymlos, they both stimulate bone formation. They work on the other end of the spectrum of that bone remodeling that we talked about. The problem with them, even though they're extremely effective at improving bone density and reducing fracture risk, is they're very expensive. Often it's a big insurance barrier to get patients these medications. And they're cumbersome in that they require a daily subcutaneous injection. You have to give it, the patient has to give it to them under the skin every day. It's also only used for 2 years at a time. The reason for that is there's a very remote risk of a particular bone cancer called osteosarcoma that has been very rarely associated with these treatments. So for that reason, it's recommended to not use it more than 2 years. So in that case, we'll often use it for 2 years and then switch them to something else, like the bisphosphonates or denosumab that we talked about before. Raloxifene or Evista, this is called a selective estrogen receptor modulator. These medications are frequently used by OBGYN docs. Basically it's an estrogen agonist, meaning it promotes estrogen in women. And that's the real issue in postmenopausal women, is they've lost that estrogen protection after menopause that they had when they were younger. So what this medication does, it kind of is it stimulates that estrogen again. The problem with it is when you look at specifically from an evidence-based perspective, the evidence just isn't there compared to the other medications. So if you're on it or if you've been on it, does not mean it's not helping you, it's not improving your bone density. It's certainly used for other conditions, not just osteoporosis. But as a primary treatment, an initial treatment for osteoporosis, raloxifene or Evista is usually not used. I want to talk about some long-term complications of these medications, and I want to bring it up because it's in the media a lot, and a lot of patients are very resistant to starting treatment. So I want to explain them, put them in context, and there are certainly things to be aware of. It all comes down to risk versus benefit with these medications, and the benefit being reducing fracture risk. The risk being, we'll talk about in a second, but what I tell patients frequently when they bring up these concerns is that benefit of preventing that fracture, which as I mentioned before can significantly set somebody back. I think that's a much more real outcome than some of these rare complications that can occur with these medications. The bisphosphonates, all of them, and denosumab have been associated with these. One is called osteonecrosis of the jaw, ONJ. This is where part of the jawbone can be damaged. Extremely rare. Knock on wood, I have many patients on these treatments. I've never seen this, but it has been reported. It's seen, if it does occur, two populations are probably at the higher risk. One are cancer patients who are frequently on these type of medications. Interestingly, those patients are slightly higher risk of ONJ. The other is patients who are getting dental work. And when I say dental work, deep dental work, there's really manipulation of the jaw, digging into the jaw, like with root canals and things like that. Routine dental work, no, but more significant dental work, there is that remote risk of osteonecrosis of the jaw. So I always recommend patients, if they are ever getting any kind of dental work, that they get that out of the way first, and then we start the treatment. And that's actually that's a relatively not an uncommon scenario. I've delayed treatment for several months until patients get that out of the way. The other is called atypical fracture of the femur, and which sounds odd because we're talking about medications to help prevent fracture, and I'm telling you that these medications have been implicated in fracture. But they're atypical, meaning that they occur at strange sites, specifically the long bone, the femur, right in the femoral shaft, like this person who's had an atypical fracture due to long-term use of a bisphosphonate. And it's only seen with long-term use. And the reason for this, not completely understood. It's kind of an ongoing, still being looked into, but what's going on with this is it goes back to bone remodeling. What we're doing with these medications is we're again shifting the balance, preventing bone from being broken down. And again, that bone remodeling process is what creates nice, strong, tensile bone over the lifetime. What we know now is if you do that too long, if you can get over suppression of the bone turnover, and yet it can end up changing the architecture of the bone if you change that balance for too long. So patients who've been on these medications for years and years, in some cases 15 plus years, been on Fosamax or alendronate or risedronate, these are the patients who are experiencing these atypical fractures. It is not occurring in the short term. There's tremendous benefit with these medications with short-term use, meaning a few years. But long-term use, we really need to be cognizant of that because this is a potential outcome. So that gets into this idea of treatment holiday. And this is an evolving recommendation. There are not concrete guidelines right now. And what I'm telling patients now might be different, a year from now, 5 years from now. But ultimately, a treatment holiday should be considered to help minimize some of the risks that I just talked to you about, specifically the atypical fractures that are rarely associated with these medications. So what's recommended that in somebody who's been on treatment for several years, that if their bone density is stabilized, that you need to stop the medication. And in the past, a decade plus ago, patients would be started on these medications and just left on them forever, thinking that it's helping you keeping your bones strong. And we realized, no, that's not the right approach, that there should be time frames that we use these medications, when to start them and when to consider stopping them. So when it comes to the bisphosphonates, in patients who are low risk for fracture or moderate risk, we usually will treat for 3 to 5 years. 3 years for zoledronic acid, reclass, 5 years for risedronate, Fosamax, and if they're risedronate and alendronate. And after 3 to 5 years of treatment, if their bone density is stabilized, then we'll do a holiday off the medication. We'll monitor. In patients who are very high risk, so those patients who have very low bone density, who've had multiple fractures, those are patients that we might extend treatment up to 10 years before considering a holiday. But in a lot of patients, we can consider stopping treatment after 3 or 5 years of treatment. So after stopping it, what do you need to do? So what I do is I recommend checking a bone density roughly 1 to 2 years after stopping it, just to make sure everything's stable. And if it is stable, then we'll continue to hold it. The one thing to note about these bisphosphonates that we talked about is they stay in the body a long, long time, years. And the studies have shown that if the benefits in improving bone density and reducing fracture risk are maintained for years after stopping it. In the case of alendronate, stopping the medication, you can still get a residual benefit for up to 5 years. That's been shown in studies. For reclassed zoledronic acid, stopping the medication, you can get residual benefit for 3 years after stopping it. So even though you're on a holiday, you're really not truly on a holiday. That medication is still in the system exerting its effect. Treatment monitoring. So you've been committed to a treatment. How often do we need to be checking a bone density while on treatment? So after initiating treatment, I usually like to check a bone density 1 year after starting treatment, just to kind of check in on the bone density, make sure it's at least stabilized or heading in the right direction. Sometimes that's an insurance barrier and we can't do it for 2 years, especially with Medicare. But after initiating or changing treatment, a bone density 1 to 2 years after. And then if you determine that the medication is working, and you're going to maintain it, then I usually check a bone density every 2 years. Patients who are high risk, specifically like those who are on long-term steroid use, I usually check it on a yearly basis. But again, sometimes that's an insurance barrier. So I'm going to leave it there. And I believe Dr. Guest is going to talk a little bit about fall prevention.
This will be a little bit shorter. My name is Dr. Peggy Guest, and my specialty is physical medicine and rehabilitation. And this evening I wanted to talk to you about a program that we developed here at Christiana for fall prevention. And the name of this program is called our Safe Steps Program, which is located at the Wilmington Hospital, 5th floor Gateway building. And every day, we know that older adults are falling or have a fear of falling. But the good news is that falling is not a normal process of aging. But we know that falls can cause significant injury, hospitalizations, loss of independence, and even in some cases, death. During this office visit or our program called Safe Steps, it is a multi-specialty medical evaluation with 2 physicians, myself and Dr. Lindsay Brandt, who her specialty is geriatric medicine. And also during the visit, we have our nurse navigators, Angel Godak and Erin Hendrickson, and a nurse practitioner that are all there present during this evaluation with you, evaluating and helping you through the process of fall prevention. We really want to identify why someone has had a fall. And during that evaluation, it really is a very in-depth, detailed history of your fall and also a physical examination. Since my specialty is physical medicine and rehabilitation, I really emphasize and look closely at someone's gait, their balance, their ambulation. Dr. Lindsay Brandt is a geriatrician, and she will look closely at your medications. Many older patients are on polypharmacy, which means that they have multiple medications that they are taking at one time, which can have side effects and may cause a fall in some patients. We also will review things like your blood pressure, making sure that your blood pressure is not dropping when you're changing positions. During the evaluation, we will be assessing your vision. We will be talking about your home safety and things at the home that may be contributing to fall. We also will have our bone health nurse navigators, and we will definitely be addressing your bone health during that visit. We also look at someone's cognition, and also sometimes just someone who has a fear of falling and the psychological factors that predispose someone for that as well. So after your visit, which is about an hour and a half long, we definitely come up with an individualized plan for each patient. And we partner very closely with our Christiana Care physical therapist and their team for recommendation and a prescription, most likely for gait, balance, strengthening, and fall prevention. We also can recommend some home modifications, some medication recommendations. Some patients require some bracing for lower extremity to help them with their gait, and some patients just may need an assistive device to prevent falls. So as of today, our Safe Step program has demonstrated a great success. Greater than 50% of our patients are coming and in their follow-up appointments saying that they've had a decrease in their falls. So we're really excited and happy to be able to offer this program here at Christiana. And today with me I have Aaron McConnell, who is one of our physical therapists with Christiana, and he's going to be speaking about some of the physical therapy program.
I'm going to have everyone please stand up. All right. Everybody sit back down. All right, everyone stand up, but this time nobody use your hands. How many people caught themselves using their hands? It's okay. All right, then have a seat again. So, from that perspective, it's just an indication to me if someone really requires their hands to get up, there might be something slightly off in their balance. Another easy way to do that, come on back up into standing. Promise, I'm not going to make you do this over and over again. Maybe. All right? What I want to do is just walk forward to the chair that's in front of you and just put your fingertips lightly on the chair. Now, you can pick your foot, doesn't matter. I want you to just pick one foot up off the ground. Okay? Now let go of the chair if you feel safe to do so. Okay? Now, what I want to do, as long as you're comfortable doing it, try it on the other side. Is it different from one side to the other? Or was it super wobbly from one side? Because when do we do a lot of this? We walk. Okay? So how someone looks standing on one foot, I can wager that's also how they look when they're walking. Which again is just that indication for need for possible therapy. And it might not be a lot, just to be able to address some measure of balance dysfunction that's occurred that increases someone's risk for fall. And then back to what I was saying before about the signaling, our bones need the message to say we need more bone. Just like when we strengthen our muscles, that requires a signal to our muscles to say, okay, here, we need to do more of this. We need to build more of this. Bone isn't any different. One of the simplest ways that we can all do that, everyone did it to get here, or at least partially to get here. Walking. Every time your foot hits the ground, it's more than just your body weight. It's actually more than your body weight because of the effects of gravity and the impact that occurs. And technically, the more impact equals more stimulus for bone. Obviously, if we exceed that, which is what we've talked about already within the fractures, all right, that is well in excess of what that bone can handle. You can all sit down if you like. You don't have to stay standing. So within that, we want to be able to load the bone. Now, obviously, walking is easy enough because that helps to load your lower back, long bones of the legs, but doesn't necessarily impact the arms. And that's where we would necessarily need some measure of strength training. It doesn't have to be a lot. You don't have to become a bodybuilder and bulk up. But you do need that stimulus to the system of pushing and pulling, creating that compression of the bone in order to be able to signal it to say, okay, we need more bone here. Because we could have perfect nutrition, but if the bone never gets the message that says, hey, we need more of this, and then the body sees no reason to do anything about it. So in order to be able to help to maintain our bone density, we should participate in loading activities. Now, whether that's walking or strength training, and particularly as we age, I would argue that strength training is even more important because we lose that bone density and we lose that muscle mass as we age. And so in order to be able to maintain that, we want to be able to participate in exercise. Now, if you're not feeling safe to participate in exercise or you don't know how, again, that's where physical therapy or personal trainers can come into play to be able to address those problems and provide you a starting program to be able to advance forward and learn how to safely work on your balance and loading of the bones in order to be able to communicate to the body that we need more bone, because more bone basically helps to facilitate greater resilience. So if we do happen to fall, the higher density of the bone also reduces the risk for fracture. Do you have any questions?